So just briefly, we're going to do a talk to reflect on the functional design of the EMG data collection that we went through the process in preparation for giving that information to the teams who are inputting the algorithms in for the AiBle robot. If you could move on to the next slide. So we're going to be looking at the design considerations for the data collection, the process that we went through, the learning points, and the application for the project. Next slide. Thank you. So when we think about normal movement, as we all know, we think about the nuts and bolts of the musculoskeletal system, having the correct alignment and muscle tone to allow effective and efficient activation to move our bodies towards a specific outcome. So for example, reaching for a glass of water, bending down to pick something up off the floor, giving our children a hug, or saving ourselves from falling if we trip. Next slide, please. But there are lots of other things that we need to consider to prepare ourselves for this movement. So there are many components that influence normal movement, even before we try to initiate moving out of our resting postures. And following a stroke or a neurological condition affecting the brain, many of these systems can be affected. So when we look at the prevalence of cognitive deficits following a stroke, a profile by the Aspire-S study looked at longitudinal evidence regarding long-term implications of cognitive impairment. And it said that 22% of the 250 patients in the sample size had ongoing deficits at 5 years post-stroke and 21% at 14 years. So it's a big implication when we're thinking about our patients and the type of movements we're going to be asking them to be doing. Next slide, please. So to go into a bit more detail, the cognition is an umbrella term which encompasses many skills that we that we use to be able to understand and interact with the world around us. And it's a fundamental consideration when supporting someone to achieve movement of any kind. At the very foundation of our cognitive processes, we need to be able to attend to the task we are trying to complete. So many patients and stroke survivors have reduced attention capacities and therefore need a variety of support strategies to remain focused in the simplest of tasks, such as washing their face, right up to much more complicated tasks like making a meal or managing their finances and multitasking. If someone's unable to attend to a task or instruction for long enough, then they are unable to process the information, be that visual, auditory or tactile, in order to understand what is required of them, and therefore unable to complete the appropriate response to be successful. Similarly, in planning and sequencing skills, it can affect the individual's ability to effectively organise and order movements or to sequence activities within a specific task or game. Memory is key to allowing someone to access previous motor programs or functional memory from past experiences to be able to relate it to current stimuli and place the immediate information they're receiving into a context. So having access to an effective cognitive system allows us to actively engage in tasks, access our motivational drive, and to be able to initiate activity and problem solve the tasks and games, and then to evaluate and modify our movements to allow us to be successful. We must also be aware that patients with brain injury or strokes have a reduced cognitive capacity and therefore can become cognitively fatigued. As a therapist, it's important to be aware of the specific behaviours and neurological signs that indicate that the patient has reached cognitive saturation. So, next slide, please. Another aspect for consideration when thinking of asking our patients to interact with any object or piece of neurotechnology is vision. Our visual system plays an integral role in perceiving the world around us, including the objects that we want to interact with. Many stroke survivors will have a visual deficit of some form, which will reduce their ability to successfully see the world around them. These might include hemianopia, visual neglect, diplopia, a reduced ability to track objects across a visual field, reduced ability to converge their gaze on a single object, and an altered depth perception. Changes in vision will have a direct impact on cognitive fatigue, because before they are even asked to complete a task, they will continuously be trying to make sense of their visual world. And some patients will automatically develop compensations for this change in vision. And we may see behaviours such as closing an eye or altering their head position to accommodate for visual field loss. As a result, how we position our patients in front of functional objects or computer screens or neurotechnology will vary depending on the nature of the visual deficit. And we may choose to adapt these tasks to support the patient. For example, reducing the amount of information on the screen to support visual processing, or making colours on the screen more contrasting, brighter or larger object outlines, or written information. And we may set the object orientation to be within that person's specific visual field to allow for success in tasks and games. Next slide, please. Okay, and finally, to consider altered awareness of self. So changes in a person's sensation through their skin or joint position awareness can vary from mild, such as areas of numbness or pins and needles, through to complete sensory loss of a limb. And we all know how it feels when we get pins and needles, so we're trying to move our hand, but it's just not quite responding. The sensory loss will affect the person's ability to be able to find or localise specific muscle groups and successfully activate their hand and limb through a complex pattern of movement. Changes in sensation are also really important to consider when fitting any device to a person's limb, as the individual may not be able to inform you when or if the device becomes uncomfortable or painful, and they would be at risk of pressure areas or skin marking. An altered perception of one's body or environment can mean that the individual does not include their affected side in their functional activities. And this presents as an inattention or a neglect of a limb and can occur due to altered perception of sensory information. To the individual, that limb or part of their visual field just doesn't exist. And this is key to consider when we as therapists are trying to engage our patients in a specific piece of neurotechnology that aims to facilitate movement, vision, and cognition in multiple planes and directions that the individual may not be comfortable moving in. Next slide, please. Thank you. So with all of that in mind, we had to decide what sort of movements we would be asking our participants to do to enable us to get the best quality and the most appropriate type of EMG readings. So thinking about the types of movements, we collaborated really closely with our French partners and decided to keep the movements as meaningful to everyday tasks as possible for the patients. So therefore we used reach and grasp movements and based them on functional tasks that would be experienced repetitively on a daily basis, such as reaching for a glass on the table in front of them, reaching onto a raised surface like a cupboard. So I'm just reading the comments as they pop up. Reaching up into a raised surface like a cupboard, pouring a glass of water, opening a jam jar, and cleaning or wiping a surface. All movements were completed across multiple and predetermined trajectories, and objects and reach points were systematically measured and positioned at the individual's mid-range to allow for more comfort and also reduce the amount of forward flexion in the torso. A selection of familiar objects were used consistently with each patient: a water bottle, a glass, a ball, and a jam jar. And by using these items, we were able to achieve and record EMG data of the forearm at different degrees of pronation and supination, with the hand in different functional grasp patterns. The programme of movements and the object placement was standardised, and this was shared with the French clinical team to ensure that there was continuity and consistency across both sites. Next slide, please. Thank you. So now we're going to move on to the next reader, which I think is Lizzie.
Thank you, Laura. So following on from Laura, we then knew what tasks we were going to be including, and we needed to recruit appropriate patients for the EMG data collection. Next slide, please. As Laura said, we collaborated with our French clinical partners to set out appropriate parameters for inclusion and exclusion. As you can see on screen, these range from more apparent criteria, such as muscle activity, and then we thought through to consideration of the participants' mood and motivation to engage with the data collection process. Next slide, please. So whilst the inclusion and exclusion criteria were being finalised, we asked clinicians across all Hobbs Rehabilitation sites to liaise with clients who had a diagnosis of stroke and input those who consented into a central database. We then circulated the agreed inclusion and exclusion criteria to our staff and asked them to review this in relation to the appropriateness of participation. Once that was completed, we then began to make initial contact with the clients to discuss the EMG data collection process and send out information packs. A follow-up telephone call was then made to answer any remaining questions and book participants onto a data collection day. Next slide, please. So in total, we had 57 clients entered into the database. Next slide. 46 of which met the inclusion criteria and 11 were excluded at this stage. Next slide. Contact was then made with 35 clients, 4 of whom declined, and 11 appropriate clients were not contacted as the agreed target for data collection was 30 participants from Hobbs. Next slide, please. So to consider how our findings are applicable within the general population, we've summarised the participant demographics as follows. So in relation to gender and stroke, according to NICE, the National Institute for Health and Care Excellence, around 51% of strokes occur in males and 49% in females. We had 19 male and 11 female participants, giving us 63.3% male and 36.67% female, meaning we had a higher percentage of male participants than that of the average in England. Next slide, please. When it comes to the type of stroke, 22 participants, or 73.33%, had an ischemic stroke, or 8 had 26.67% of our participants had hemorrhagic strokes. This gives us a lower than average percentage of ischemic strokes, as in England, approximately 85% of strokes are ischemic, with only about 15% being hemorrhagic. Next slide, please. Furthermore, of the side affected by the stroke, we had 16 participants with right-sided impairments and 14 with left-sided impairments, almost splitting it down the middle. Next slide, please. We also need to cover the age of the participants. According to the SNAP National Database, the average age for a new stroke was 76 years old between April 2020 and March 2021. The average male age was lower at 73 and the average female age slightly higher at 79. Our participant age range was from 30 years old to 86 years old, with an average age of 60.1 years for all of our participants. Our average male age was 61.9 years and our average female age comes in slightly lower at 57.1 years old. This shows a younger participant demographic than that of the national average. Next slide, please. To conclude the participant demographics, we have on screen how long post-stroke our participants were during the data collection process. All of our participants were in the subacute or chronic stages of their stroke, with 7 participants less than a year post-stroke. The shortest amount of time was 4 months post-stroke and the longest was 17 years post-stroke. But overall, the average length of time for our participants was about 4 years since their stroke. Next slide, please. So now that we had our participants, we completed a staff training day to familiarise ourselves with the process and ensure that each participant would have a similar experience. In the training, we covered outcome measures, data recording procedures, functional task setup and facilitation, as well as spasticity and joint range of motion assessment. When completing joint range of movement measurements, we chose to use an app called the Coach's Eye, as it allows the therapist to superimpose joint measurements on a video of the participant completing the movements, and this helped with accuracy and efficiency of the process. You can see a picture of me on screen doing some shoulder flexion, where we then put in the superimposed joint measurements there. For the data collection, we initially allocated 3 of our staff members per day to complete this process. However, with a little practice, we were able to streamline this and completed the majority of our data collection days with just 2 of our staff members. We were able to see 2 participants a day and completed 2 days of data collection per week between May and July 2021. Next slide, please. So every participant would begin their day with the consent paperwork and games questionnaire. The games questionnaire was completed to gain feedback on previous gaming experience, use of neurotechnology, and insight into participant opinions on potential games for the AiBle project. And then once the paper-based tasks were completed, we would then commence the physical aspects of the data collection day. To be able to document and store the data from the following assessments, we used a live document for each participant that was saved straight into their participant folder on our secure cloud. With each participant, our therapist completed a Fugl-Meyer upper extremity assessment, modified Ashworth scales of the elbow and wrist flexors, and joint range of motion recording for the affected upper limb. Next, the participant would don the EMG sleeve and complete the functional movements independently or with therapist facilitation. We're not actually part of it. The EMG recording was completed throughout the functional movements by the team from Portsmouth University. To finish, we completed grip strength testing with a dynamometer, and overall this process would generally take anywhere from 90 minutes to about 2.5 hours. Next slide, please. So this brings me to further discuss the outcome measures that we used in more detail. And from Karen's presentation, you may notice that these are both clinician reported outcome measures. We chose to use the Fugl-Meyer upper extremity assessment and grip strength assessment. Karen already touched on the Fugl-Meyer upper extremity assessment, and to quickly recap it, it is an outcome measure that is used to assess motor function, sensation, joint range of motion and pain. And when repeated, it can be used to monitor and track individuals' recovery post-stroke. And then, as Karen mentioned also, it is widely used, it doesn't require any specialist equipment and is internationally recognised. And as I said, we chose the Fugl-Meyer upper extremity assessment also because of its high reliability, validity and feasibility. Secondly, we assess grip strength. Research has shown a positive correlation between strength and functional recovery, as well as in the chronic phase, it's strongly associated with muscle strength in the whole arm. This was completed using a JMAR dynamometer with 3 trials for each participant, and an average was then taken. Again, this outcome measure has high reliability and validity. Next slide, please. A quick glance at the results of the outcome measures offers insight into the variety of functional levels that we worked with throughout the data collection process. The average Fugl-Meyer upper extremity score was 84 out of 126, with a higher score having milder impairments. We had 1 participant who scored 126 out of 126, demonstrating no residual impairment on this scale. Conversely, the lowest Fugl-Meyer upper extremity score was 42 out of 126, implying severe impairment. Interestingly, if we separate the motor and non-motor elements of the Fugl-Meyer upper extremity, we can see that the non-motor scores that are relatively similar across all participants. And you can see that in the slightly darker red colour on the scales there. And you can see if you look from left to right across it, they all sort of stay in a very similar position. When we look at the motor scores, which are the lighter red ones across the top of it, you can see that there's a lot larger variation in the size of that there. Just highlighting that there's quite a big variation in the functional level of the participants we had. Next slide, please. Similarly, when we look at our grip strength, we can see that there's a large range of results. The average grip strength came in at 13.4 kilograms, with the highest participant average at 47.3 kilograms, and 5 participants recorded 0 kilograms or not readable. This again demonstrates the variety of ability of participants in this process. Next slide, please. So traditional outcome measures, albeit insightful, were not the primary purpose of completing the data collection. The main objective was to collect EMG recordings of post-stroke individuals completing functional movements. To get this data, the participants each wore an EMG sleeve that came in 2 parts, one for the upper arm and one for the forearm. The sleeve had 32 electrodes, and the Portsmouth University team used these channels to record muscle activity during the functional movements. The initial EMG sleeve was wired. However, the team from Portsmouth University opted to swap this to a wireless alternative to aid with therapist handling, as well as the quality of the data received from the sleeve. Please see on screen the photos of the wireless EMG sleeve. I'm now going to hand over to my colleague Ali to take you through the functional movement data collection and analysis in more detail. Thank you.